My name is Dr. Chandra Shekhar. I'm a nephrologist. Today I'm here. I was given an opportunity to meet you all and greet you all with a topic, diabetic kidney disease. It's, I think, primarily just so we all know each other and get to know. So let's start. Where is it? So, diabetes is a leading cause of chronic kidney disease and end-stage kidney disease, not just in India. In India, definitely, and has also a lot of the parts of the world. And India, I think, in this year has become the most populous country. I don't know if it's already become crossed to China or not, but if not, the statistics say that it's going to soon do it within the next few months. And within that, like, we are expected to have the world's largest population with diabetes by 2030. Right now that credit is with China, and very soon we'll have the world's largest population with diabetes. So if we are having such a huge burden of diabetic patients, there is a statistic that about 1 in 3 diabetics have diabetic, 1 in 3 diabetic adults have some form of diabetic kidney disease. So you can see how much of diabetic kidney disease burden we nephrologists have to deal with. So I thought it's a very good topic for me to discuss and bring a bit of awareness about how we diagnose it, how we treat it, and what's the guidelines, what new drugs that are available, and things like that. So both diabetes and kidney disease are now in the top 10 leading causes of death all over the world as per the WHO Global Health Estimates in 2019. If you curtail that specifically to India, I've seen that kidney disease is there in the top 10 leading causes of death in population from 30 years onwards upwards. So only in people that are less than 30 years, kidney disease is not there in the top 10 leading causes of death, but it's there in India, in the Indian population, and it's also there in the world. So as of 2021, there were about 74.2 million diabetics in India. That's in 2021. So a third of that, I think, I don't know, about 25 million or so people have diabetic kidney disease in India. And there are about 4,000 nephrologists. I heard that there are about 4,000, less than 5,000 nephrologists are there in India. And a lot of them are specifically there in urban areas like this city. So a lot of disease, and this is only diabetic kidney disease I'm talking about. So how does diabetes cause kidney problem? So when there is a lot of glucose in the blood, and it gets filtered through the glomerulus into the Bowman's cup, and then it passes through the proximal tubule, usually that is where the glucose gets reclaimed back through the sodium glucose co-transporters that are there in the proximal tubule. So when there is a lot of glucose coming up consistently, this part of the nephron gets hypertrophied over a period of time. These SGLTs 1 and 2, the co-transporters, get upregulated. And so when they get upregulated, not only the glucose that gets reclaimed, but sodium also gets absorbed along with that. It's a co-transporter, so it takes both sodium along with the glucose that is coming up in huge loads. So when there's a lot of sodium that's reclaimed, people become hypervolemic. There is sodium loading, they become hypervolemic, their blood pressures can go up, and when there is a lot of volume, that leads to, again, the hyperfiltration that leads to increased glomerular pressures. So increased glomerular pressure is the primary mechanism, is the first step through which diabetes causes kidney problems. And then there are other things like, RAS activation, renin-angiotensin-aldosterone activation, that leads to renal hypertrophy, increased renal plasma flow, and elevated single nephron GFR. It's the same as the whole hyperfiltration we were talking about. And also the other thing is, when there is a lot of sodium that is being reclaimed in the proximal tubule itself, very little sodium goes to the distal parts of the nephron, which is where the macular densa is there. And so that is the place, the juxtaglomerular apparatus, which senses how much sodium it's receiving, and when it thinks that very little sodium is coming, it thinks that the kidney is underperfused. So what it does is, through tubular-glomerular feedback, it tells the afferent arteriole to dilate even further to allow more blood, so that further increases the intraglomerular pressures. So it's just a schematic to show you the various factors that contribute to hyperfiltration both in the afferent side and efferent side. I'm not going to go through the details. So this hyperfiltration, studies have found that hyperfiltration is associated with increased risk of moderate to severe albuminuria, and albuminuria is the single most strongest risk factor for chronic kidney disease development, diabetic kidney disease development. So controlling glomerular hyperfiltration is the primary mechanism by which we try to prevent diabetic kidney disease among diabetics. So how do we do it? We use ACE inhibitors or ARBs, basically RAS inhibition, and SGLT2 inhibitors as well, because if you remember, we just spoke, the primary way the whole thing starts is by absorption of increased amounts of glucose, which leads to hypertrophy of the proximal tubule. So if we block that part where there is a lot of sodium and glucose that is being reabsorbed, we prevent this whole cascade of things that progress to diabetic kidney disease. So there are various mechanisms in which there are various pathways through which diabetes causes kidney disease, and among them there is glomerular basement membrane thickening, mesangial cell hypertrophy, whether it could diffuse or nodular, there is matrix accumulation within the mesangium, macrophage infiltration, vascular proliferation, VEGF mediated, and this is the same mechanism in which proliferative diabetic retinopathy also happens. So it's VEGF mediated, and you might know that in people with diabetic retinopathy they give bevacizumab injections, and basically it's to stop this VEGF mediated vascular proliferation. The same thing happens in the kidney too. So there is increased endothelial permeability, podocyte loss, that's what leads to nephrotic syndrome. The podocyte integrity is what keeps the protein from not leaking into the urinary side, but that's what is lost. There is interstitial fibrosis, tubular atrophy, and these are all the various mechanisms that happen to different degrees, leading to a wide array and a wide variety of problems in diabetic kidney disease. So when we come to risk factors, there are certain modifiable risk factors and certain non-modifiable risk factors, like any other condition. So age is one such non-modifiable risk factor, and as the age progresses, the probability of diabetic kidney disease with decreased GFR goes up. So as the statistic says, there's about 8% chance in 5th decade in people among diabetics. And it goes up to 19% by 6th decade and 35% by 7th decade of life. CKD in general and diabetic kidney disease is a bit more likely among women, but in males what we've observed is that once they reach the advanced kidney disease stage, their progression to end-stage kidney disease goes pretty quickly among males. That's the gender differentiation we've seen. And low socio-economic status is another risk factor because they don't have access to the knowledge that they need to know. They don't have access to the care that is needed. So their disease progresses without any checks. And then obesity is another risk factor for worsening of diabetic kidney disease, because the features that we see in obesity-related glomerulopathy, which is a form of secondary FSGS, they are very similar to what we see in diabetic kidney disease. So it intuitively makes sense that the pathway through which obesity causes kidney disease is shared by the hyperglycemia-related kidney disease, and so in people who have diabetes, if they're also obese, their probability of ending up with a renal pathology is much higher. The features are more pronounced in visceral obesity, that is the truncal obesity people, than in general obesity. Smoking, as you all know, is a major risk factor, and we've noted that we've seen some biopsies in the past as well. Smoking-related glomerulopathy, some of the features, the nodularity of the glomerulus and all, it's very similar to what we see in diabetes. So even in people who do not have diabetes, when they are smoking, some of the features that we see in the renal biopsy are similar to what we see in people with diabetes. So that also, like I was saying earlier, it shares a common pathway in the pathogenesis of the glomerulopathy and causes problems. So the endothelial dysfunction, oxidative stress, and the inflammation are probably the common pathways through which both diabetic kidney disease and smoking-related nodular glomerulosclerosis affect the kidney function. other risk factors are hyperglycemia. So people who have diabetes, if their glycemic control is poor, then obviously their kidney disease is likely to worsen much quickly. So glycemic control is of paramount importance in controlling diabetic kidney disease. We talked about this hyperfiltration and proteinuria and all these things. So in people who had all these, like proteinuria, hyperfiltration as monitored on the GFR, once we control their glycemic status, we see that these things, some of them even get reversed. So albuminuria improves, the hyperfiltration will come down, and so the rapidity at which their GFR can decline will be slowed down. Hypertension is another major modifiable risk factor, and among diabetics, we try to keep their systolic blood pressures less than 130 and diastolics less than 80 millimeters of mercury. And there were studies which showed that if the systolic blood pressure is more than 140, and it has been shown to increase the risk of development of severely increased albuminuria, and the stages of the kidney disease will also go up, which is basically the GFR will go down. Acute kidney injury is another risk factor. People who end up with multiple episodes of acute kidney injury are more likely to develop CKD among diabetics when compared to non-diabetics, because each time they develop acute kidney injury, their recovery is not complete. The diabetes, underlying diabetes, what it does is it creates certain maladaptive repair processes. So when their creatinine goes up and when it's trying to recover, the diabetic kidney disease doesn't allow them to recover back to normal or even close to normal. So each time they have AKI, their recovery is not complete, and it's like a stepwise pattern in which their kidney function gradually goes down. So people with diabetic kidney disease, AKI is not a good news. So after the risk factors, how do we diagnose diabetic kidney disease? The gold standard is kidney biopsy, but because of the burden, the number of people, and not everyone can have kidney biopsy in all the situations, there's so much of diabetic kidney disease patients we see that it's almost now become a clinical diagnosis, because if patients have albuminuria in the context of long enough history of diabetes, or if they have reduction in GFR, or a combination of both. They can have either albuminuria or reduction in GFR, or both. Usually the both, when they have both, it's advanced stages of kidney disease. They can't have only albuminuria or only reduction in GFR when it's in the advanced stage. It's in the initial phase, you see either this or that, or both. And if you have a history of diabetes for long enough time, and there are no other signs or clues to suggest that there is an alternate diagnosis, alternate etiology for the kidney disease, we consider that as diabetic kidney disease. It's a clinical diagnosis for the most part. And often, even when we diagnose diabetic kidney disease clinically, when we monitor them, if there is a sudden change, if there is change in the way the disease behaves, like we suspect that something else might be going on, then we obviously go for a kidney biopsy at a later stage. Like if there is a sudden change in the amount of albuminuria, a sudden decrease in GFR, or some other new rash that you've developed, joint pain, whatever. If there is something else that directs us to an alternate etiology, that's when we do a kidney biopsy. Otherwise, for the most part, it's a clinical diagnosis we establish without a kidney biopsy. Higher levels of albuminuria and lower levels of GFR independently and additively increase the risk of cardiovascular events and death. So the things that we talked about just now, the reduction in GFR and increase in proteinuria in the urine, those are the signs through which we can detect diabetic kidney disease, but unfortunately both of these are asymptomatic. People, unless they have really nephrotic range proteinuria, they don't know that they have proteinuria. The foamy urine that we describe is not existing in the mild and moderate sort of albuminuria, which is also a risk factor, but people don't know. And even in people who have severe albuminuria and they have foamy urine, a lot of patients, they consider that as a minor or some sort of symptom that they're not worried about. And the drop in GFR, most people don't have any symptoms when their GFR is going down from whatever, it should be 100 or something, and as it is going down until 20 or so, which is 80, 80 ml per minute of GFR dropped. Until then, people don't have any symptoms. So only in advanced stages of CKD do patients have some kind of symptoms, and that too vague symptoms like fatigue and restlessness, not being able to sleep, no appetite, that kind of symptoms, and they don't know where to attribute these symptoms. So unfortunate thing with diabetic kidney disease or with a lot of the kidney diseases is that they don't have symptoms. It's not like heart attack and things like, oh, I have a chest pain, and they immediately rush to the hospital. So kidney disease patients don't present by themselves until it's too late, or if they're lucky, they get presented because incidentally some doctor found and they came for something else. So it's really important for us physicians to detect the kidney disease early in the early phase itself, to be able to treat and prevent further progression. Because this kidney disease, once it progresses to the advanced stage, there's nothing else we can do to reclaim back what's lost is lost. So that is why it's important for us to advise annual testing for everybody. If they have diabetes, we should be looking at their creatinines. Even if they are normal, we should be looking at their serum creatinines and urine albumin creatinine ratios at least once a year, and if they're abnormal, once every 3 months to 6 months, depending on how severe it is. If we find a newly diagnosed type 2 diabetic, we assume that they had this diabetes undiagnosed for X number of years, and so we do this testing for the kidney disease, like the albuminuria part and the GFR in the beginning itself. But for type 1 diabetes, usually we don't necessarily have to do that, because usually they get diagnosed immediately, and so we can wait. If they have had the diagnosis for more than 5 years, that's when we start looking for kidney-related issues. How do we manage? So, like we talked about the risk factors. So first thing is, like, whatever modifiable risk factors we have, we try to address them, we try to mitigate them and minimize them, and we reassess our performance once every 3 to 6 months to see whether, if somebody is smoking, we ask them every 3 months, have you stopped smoking? If there's a weight problem, the BMI is so high, we keep checking them every 3 months to see whether the BMI is coming down into the target range that we have. If it is cholesterol, we look at the cholesterol, LDL, and all these things. So we frequently appraise his values and continue to optimize the risk factors, the modifiable ones anyway, to the best we can. So, like I talked about earlier, albuminuria is the strongest risk factor for progression of diabetic kidney disease. So, if people have albuminuria, we have to control it as much as we can. And the medicines that we use are RAS inhibitors. So, ACE inhibitors or ARBs are the primary stay of treatment to try and control the albuminuria. So, depending on how severe it is, the dose that we need to put them on depends, but we try to maximize the RAS inhibition to give them the maximum benefit of controlling the albuminuria. We try to bring them from severe albuminuria to moderate risk, and from then moderate to normal, which is less than 30 milligrams per day of albumin excretion in the urine. That's what we try to do. And it's not just ACE inhibitors and ARBs. Recently, we also started using SGLT2 inhibitors in type 2 diabetics. ACE and ARBs can be used in both type 1 and type 2, but SGLT2 inhibitors, we can only use them in type 2 diabetics. Very recently, a new molecule has come up, which is a non-steroidal selective mineralocorticoid receptor antagonist. So previously we used to use these steroidal MRAs, which are spironolactone, eplerenone kind of thing. But now, recently, there is this non-steroidal one, which there are studies which show that there is some benefit in using that. Among patients who have already been on maximally tolerated RAS inhibition, if you keep them on finerenone, the new drug, then there is some added benefit seen in those patients. I put a slide at the end, I'll show. And then, like I said, hypertension control. The goal should be, among diabetics with kidney disease, the goal should be less than 130 for the systolic and less than 80 for the diastolic. We would have already put them on ACE inhibitors or ARBs for controlling the proteinuria, and that certainly helps control the blood pressure. But if that's not sufficient, we obviously go for next level treatment, which is either finerenone, that's also a mineralocorticoid receptor antagonist, it controls the blood pressure to some extent. If not, we go for calcium channel blockers, diuretics, depending on whether they have swelling, hypervolemic, potassium levels, and so on and so forth. So that is all targeted therapy. Once we establish the baseline treatment, with the first line treatment, then we go for targeted therapy, and that's curtailed to individual needs. Glycemic control, we all know we try to achieve a HbA1c of less than 7%, but that's not written on the stone, because some people who are old, like into the 80s and all, if they have frequent hypoglycemic episodes, they have risk of falls, whatnot, and they're living alone. And such people, we don't tend to put them as strictly to less than 7%. So again, like I said, each of these goals is individualized and curtailed to their specific needs, but the general guideline is to get them to less than 7% HbA1c. And then statin use. Depending on where their LDL levels are and the total cholesterol levels, we choose to give them either a moderate intensity statin or a high intensity statin to bring their LDL levels and cholesterol levels to the target where we want them to be. And that's because a lot of the patients with diabetic kidney disease, diabetes patients with kidney disease, they are at high risk for cardiovascular disease. So in order to save them from that, and also with people can develop renal vascular disease as well, people who have high cholesterol levels. So we're trying to save the patient as a whole, not just deal with the diabetes and the kidney part, but also the cardiovascular risk factors associated with the diabetes. And then lifestyle changes. This is the first thing we do. If they're smoking, we ask them to stop, weight loss, exercise, diet, and so on and so forth. So this is a little schematic that I borrowed from the KDIGO guidelines that came last year, early last year, 2022. These are the clinical practice guidelines for diabetes management in chronic kidney disease patients. So the base of the pyramid is the lifestyle changes we're talking about. That includes the diet and exercise and smoking cessation. We talked about all these things. And then the first line therapy includes metformin, assuming that their GFR is not less than 30 ml per minute per 1.73 meters square, because that then becomes a contraindication. You all know metformin-associated lactic acidosis, MALA, is high in people who have low GFR. So we check that and make sure that they're on metformin if their GFRs are not less than 30 ml per minute. And then we put them all on SGLT2 inhibitors, all in the sense type 2 diabetics only, not type 1. And the reason we already talked about, it's basically to prevent the glomerular hyperfiltration and reduce the... And SGLT2 inhibitors also help in controlling obesity, because they'll be losing a lot of glucose through urine, and so that because of the calorie loss, they won't gain as much weight. It's good for them as well. And then we use RAS blockade in all of the diabetics, type 1 and type 2. That also prevents albuminuria and progression of the diabetic kidney disease. Assuming their potassiums are well within normal limits, they're not going into hyperkalemia range, and assuming that the RAS blockade is not causing drop in GFR by more than 30%, because in people who have renal artery stenosis, ACE inhibitors or ARBs can cause significant drop in GFR. So each of these medicines has its own little quirks that we need to be aware before instituting them. And obviously statins, we need to make sure that they're not going into rhabdomyolysis or some kind of a problem. And so those are the first line drug therapies, and then we go to the goal-directed therapy as a next level once we establish them. And like I said, they could be GLP-1 receptor agonists or other anti-hyperglycemic medicines required specifically to the patient needs as guided by the endocrinologist. And the non-steroidal MRA, which is the finerenone I talked about. And depending on the atherosclerotic CVD cardiovascular disease scoring, we also put them on some kind of an antiplatelet agent, usually aspirin. And so these days, the cholesterol and antiplatelet agent combination pills are coming up everywhere, so we use that to control their cardiovascular risk. And then lipid management, aim is to get the LDL, total cholesterol, triglycerides, all of them into the range that we want, whatever it takes. Glycemic control, blood pressure control. The same thing basically in a slightly different way. And in this chart, the green parts are the green parts are for type 2 diabetics only, because we can't use these metformin and the SGLT2 inhibitors in type 1 diabetics, whereas the blue parts can be for all diabetics, whether it's type 2 or type 1. So like we talked about, first line therapy, once we establish them on that, they're stable, then we go to the targeted therapy to control the glucose control, finerenone for the added benefit of proteinuria, controlling the proteinuria, and then blood pressure control through calcium channel blockers or diuretics, we talked about it, antiplatelet agent. And then we go further down, depending on which of them is not getting controlled, our target list of things, we go even further into controlling them. Like for example, if it is the cholesterol, we can even go for the newer drugs like the PCSK9 inhibitors, the avalosumab and alirocumab, the monoclonal antibodies. I think the avalosumab, I found out that it's available in India as Rapata or something, like it's an injection that you give in people who are resistant to, who have LDL levels that are so high and it's difficult to control them with the standard treatment. We can also go for icosapentethyl. I've been using that in some of my patients. It's basically available as Cosito, that's the brand name. And there is also evidence that it controls triglyceride levels in people who have already been established on full doses of statins. You can use the icosapentethyl to control their triglycerides further. Steroidal MRA. Usually if I use the non-steroidal MRA, like the finerenone, then I don't use the spironolactone or eplerenone. Usually I try to avoid for whatever reason, because the new drug, the finerenone Kerendia, is a little bit expensive right now. Not all of the patients take them, and in such cases I use the steroidal mineralocorticoid receptor antagonist, spironolactone or eplerenone if they have. It's just a little schematic to show how we titrate the ACE inhibitors or ARBs, because this is important in people with diabetic kidney disease. We are supposed to put this on everybody with in diabetes with any evidence of kidney disease. So once we establish them on a low and slow, we start slow. The base dose, once we start, we check their creatinine and potassium in 2 weeks' time to see what's going on. If their GFR doesn't drop by more than 30%, then we usually can continue with, and if their potassium is stable, then we can go up on the dose, like because we started slow, we can go up on the dose. But if their GFR drops by more than 30% from the baseline, then we have to suspect, is there another reason, like, is there a renal artery stenosis, is there an AKI for some reason, whatever, because ACE inhibitors also meddle with the glomerular autoregulatory mechanism, the efferent arterial part. So we need to make sure that none of those are getting affected when we are giving an ACE inhibitor. And if they're stable, then we keep up-titrating the dose until they reach the maximum tolerable dose. That's the whole idea. And that gives them the benefit of controlling the albuminuria. With hyperkalemia, usually the moment, there will be some degree of hyperkalemia the moment we put them on ACE inhibitors or ARBs, it's inevitable. But what we do is, depending on where it is, we sometimes either try to put them on diuretics or exchange resins or something to control the hyperkalemia, not just immediately as a knee-jerk reaction to stop giving them the ACE inhibitor. We try to address the hyperkalemia in a different way, but keep the RAS inhibition. But sometimes it's not possible. We have to back off or completely stop those drugs. This is a little table I obtained from American Heart Association just to show you what the low intensity, moderate intensity, and high intensity dosage of statins is. Basically, these are defined by the amount of LDL cholesterol reduction that particular statin with its particular dose achieves. So if there is LDL reduction of less than 30%, you call it low intensity dosage. Anywhere between 30 and 50% of reduction in LDL cholesterol, that's moderate. And high intensity statin is basically that reduces LDL cholesterol by more than 50%. So as you can see in this chart, there are only 2 drugs that are falling into the high intensity dosage of the kidney, of the nephron, and particularly actually in the early parts of the proximal tubule, early segments S1 and S2 of the proximal tubule. So SGLT2 is there in the kidney, SGLT1 is there predominantly in the gut, but also in the nephron, in the distal parts of the proximal tubule, or late parts, they call late segments of the proximal tubule, you have SGLT1. So what happens is, normally when the glucose gets filtered through the glomerulus into the Bowman's cup and passes through the proximal tubule, when it reaches the early part of the proximal tubule, the SGLT2 is the place where all of that glucose gets reclaimed. Actually, about 97% of the glucose that gets filtered gets absorbed through the SGLT2, and this is in euglycemic, normoglycemic phases. But in people who have hyperglycemia, when there is a lot of glucose getting filtered through the Bum's cup and into the proximal tubule, the SGLT2 is not enough to take up all of the glucose, and a lot of it, and some of the glucose gets thrown down into the tubule. So when it reaches the distal part of the proximal tubule or the late segments of the proximal tubule, the SGLT1, which normally takes only about 3%, now ends up taking as much as 40 to 50% of the glucose. So when we use SGLT2 inhibitors, the same thing happens because SGLT2 is blocking whatever glucose it takes. So SGLT1 ends up absorbing not the whole 97%, but half of it. So SGLT2 inhibitors, the reason why they don't cause hypoglycemia is because SGLT1 reclaims some of the glucose that would have otherwise not happened. So while the glucose levels go down, they don't go down to the level where it causes problems. And this SGLT1 gives us an idea that if the absorption of the glucose happens through SGLT1 in the gut, why don't we use SGLT1 inhibitors to stop the absorption of glucose from the gut itself, so that there won't be so much of a high rise of glucose as soon as they eat food and all. So there are actually trials going on with SGLT1 molecules as well, and the idea is that we can use SGLT1 after trials so that it adds up in the nephron as well as in the GI tract to control the glucose level. And actually, of all the molecules that the gliflozins, the SGLT2 gliflozins they call them, of all the gliflozins they created, they fall on a spectrum where at one end of the spectrum the molecule has high affinity to SGLT2 and not so much to SGLT1, and on the other end of the spectrum they have a lot of affinity to SGLT1 and not so much to the SGLT2. So there are molecules in the middle of the spectrum which block both SGLT1 and 2, and one end they block only the SGLT1 and the other end they block only SGLT2. This is a little schematic to show you the SGLT1 we were talking about. There are added advantages to it, like whatever glucose is left in the gut without absorption after SGLT1 blockade, we call it GGM, like it's glucose galactose malabsorption, and all of the glucose and galactose that didn't get absorbed because of SGLT1 blockage will be converted by the microbiota into short-chain fatty acids, and that through some mechanisms causes sustained GLP-1 release. And this is similar to GLP-1 receptor agonist treatment, so this helps in glycemic control. And this is the spectrum I was talking about. So if you take the topmost molecule, the dapagliflozin, it has, as you can see, about 2,900 times more selectivity to SGLT2 than SGLT1. So it's basically an SGLT2 inhibitor. But if you go all the way down to mesagliflozin, that has about 300 times more affinity to block the SGLT1 as opposed to SGLT2. So that's more like an SGLT1 inhibitor. Unfortunately, they're not available as yet. They're still in the trials. And as you can see, some of the molecules like these, the T1095, LX2761, these are all they're still in the study phase. They haven't come up with their names yet. And this fluorescein is a naturally occurring substance, and the sotagliflozin is considered somewhere in the middle. So it has that effect of both SGLT1 and 2 combined inhibition. And some of the other molecules that are available are the dapagliflozin. We use them regularly here, canagliflozin, empagliflozin, all these things. I put just a few slides to go through the evidence that we have for SGLT2 inhibitors. This is a study called DAPA-CKD study that was published in NEJM in October of 2020, where about 4,000 patients were with GFRs anywhere between 25 and 75, and a urine albumin creatinine ratio anywhere between 200 and 5,000, so moderate to severe albuminuria. These patients were randomized to either receive 10 mg of dapagliflozin or placebo. And the primary objective of that was, the primary outcome they were looking for is a composite of renal parameters like sustained decline in GFR of about 50%, whether they reached end-stage kidney disease or they had death from renal or cardiovascular causes. So this is the primary outcome, the composite of that. And as you can see in the graph, after about usage of for about 8 months or so, you can see that the graphs start separating, and so there is evidence to suggest that use of dapagliflozin has improved outcome for renal as well as death from cardiovascular causes. The hazard ratio is about 0.61. It's got a nice p-value because the confidence interval is well away from the 1 mark. And from the earlier composite, if you remove the cardiovascular things and leave it only to the renal, this is renal specific outcome, that also shows pretty good results with dapagliflozin. Same study, death from any cause, all-cause mortality also shows benefit in dapagliflozin. Hazard ratio is about 0.7. This is a different study, the EMPERIC study. It's on the empagliflozin. The reason I put that is just to show you this interesting graph. This was released in late 2015, published in late 2015 in NEJM. And as you can see here, this study, they were randomized to either receive placebo or 10 mg of empagliflozin or 25 mg of empagliflozin. And if you see, the black line is the placebo, the red and the purple and blue, whatever red and blue lines are the empagliflozin at different doses. And you can see that as soon as the drug was started, within 4 weeks, the GFR has quickly dropped, and from then it plateaued and maintained all through whatever the follow-up period of 192 weeks. Whereas in people who have been on placebo, there might have been even a little bit of a blip up, hyperfiltration. This is the hyperfiltration, exactly what the SGLT2 inhibitor stops. So initially when you start either ACE inhibitors or ARBs or SGLT2 inhibitors, their GFR drops, but that is only to increase the longevity of the kidney function. Their GFR stay at that level for a much longer period than it would have been otherwise if you put them on placebo, or if they're not on SGLT2 inhibitors. Initially there will be hyperfiltration, but the GFR gradually drops down. So this is exactly what we're trying to do. It might bring down the GFR initially and in the first 4 weeks a little bit down, but then it increases the longevity of the kidney, the GFR stays stable, and you get the benefit. This is a Figaro DKD study. This is basically to tell you about the finerenone I was talking about. Basically they chose this, within the heat map, they chose only this group of people with either severe albuminuria with mild GFRs, GFR decline, or moderate albuminuria with severe GFR decline patients. And they've excluded people with who are on dialysis and kidney transplant and really bad glycemic control and all these things. And they were those people were randomized either to receive finerenone or placebo, and the endpoints they were looking at are cardiovascular and renal composites, like the ones that we talked about. And that also, the primary outcome, we can see that after about 6 months or so of treatment, you can see that the graphs separate from there, and there is some benefit in using finerenone. And these studies were done on people who have already been completely established on maximally tolerated RAS inhibition. So we use finerenone, Kerendia, name of the drug, that's the only brand available because it's relatively new. The Kerendia, we use this drug in people who have already been fully established on ACE or ARBs to give them further the benefit of controlling the albuminuria and preventing renal and cardiovascular outcomes. Thank you.